Good afternoon, dear doctors. I'm Maha Arafa, Assistant Lecturer of Intervention and Diagnostic Radiology at Enshams Radiology Department. We are honored, me and Dr. Abdelrahman Mohee, a senior resident at our department, to represent few cases that was successfully done at both Enshams University Hospital IR units. I would like to thank our dear professors that were kind enough to share their work with us, namely Dr. Karim Abdeltawab, Dr. Wissam Shireen, Dr. Ahmad Aouqba, Dr. Rana Tarek. As you all know, emergency intervention radiology has become an integral part of the medical emergency team, as it is provide a pivotal clinical service in the management of emergency patients. We are proud to have a 24-hour emergency on-call IR team in Enshams University Hospital, which deal with the basic access cases to advanced cases, such as thrombectomy and the critical hemorrhage control, which could either be controlled by could be managed by invasive surgical technique or minimal invasive technique, as we call the magic techniques. Our talk scope will include the access presentation about the emergency IR rule in various fields, including urology, GIT, pulmonology, and general intervention radiology. Case number 1 is about adult male patient enters the ER with severe left flank pain radiating to the back of 3 days duration, progressive, not responding to analgesic. Vague history of similar attack a few years ago that required hospital admission. Vital data was slightly tachycardic, yet the patient was otherwise vitally stable. His TBC was hemoglobin 11.6, low normal. So the ER proceeded to ultrasound as a preliminary investigation to know the cause of the pain. As we see here, there is a large hyperechoic left perinephric hematoma. So a triphasic CT was ordered to localize the pathology and identify the bleeder. In the first video, we are showing the arterial phase. There was a direct extravasation and active bleeding from the superior branches of renal artery. A hypertrophied left suprarenal artery is also noticed. And also we see here in the venous and the delayed phase, the pathology was more clear as the heterogeneous lesion with both fat density and the blood density. Diagnosis was reached as a ruptured angiomyolipoma. The decision was taken single-handedly by the urology department. Patient was admitted and the conservative management was decided. After 24 hours, the patient condition deteriorated and entered in a shock state that required ICU admission, as the patient was hypotensive tachycardic with profound hemoglobin drop. The IR unit was sought for advice, so our team responded immediately for an emergency embolization under local anesthesia, and DSA was done. DSA revealed supply to the angiomyolipoma from the superior branches of the renal artery, as shown in the first and second video. Embolization was done using sclerosant agent and spheres. Control angiography revealed intratumoral bleeding from ruptured vessels. Embolization using gel foam was done. Supply from the suprarenal artery was suspected from CT and confirmed by diagnostic angiography. Embolization was done using a sphere. Post-embolization follow-up was impressive, as the patient condition, according to the urology department, discharged from the ICU after 2 packs of blood in the same day. Then he was discharged to his home in the same week to follow up as an OPC and the elective excision of the remnant of the tumor. So his life was saved. The learning point from this case: angiomyolipoma is a benign renal tumor that carry high risk of life-threatening hemorrhage. Indication for treatment include masses of sizes greater than 4 cm, symptomatic masses like hemorrhagic and painful masses. Options for treatment ranging from nephrectomy, selective arterial embolization, ablative therapies including cryo and radiofrequency. The most common used embolic agent is ethanol lipidol mixture, large particulate agent as spheres, and the BVA. Combination of both as done in our case. Search for extra renal supply in large lesion is mandatory. The second case, as we all know, GIT bleeding is one of the most common embolization we face In our daily practice, here is two cases about GIT bleeding. The first one is about 45 years old male patient, known case of duodenal ulcer by the endoscopy. Recurrent attacks of hematemesis. The patient underwent endoscopy collapse application, it fell away with recurrence of bleeding, so referred for embolization. Initial gastroduodenal artery catheterization revealed no bleeding, likely due to blood clot. So provocation angiography was done by 5,000 units of heparin and papaverine as a vasodilator, revealing marked duodenal extravasation. Anchoring of a microcoil at the bleeder to the gastroduodenal artery was done with the cessation of bleeding. Control angiography revealed no more bleeding. The patient condition was stabilized. The second case is about adult male patient with acute severe attack of hematemesis, underwent endoscopy that failed to identify the bleeder, yet reported blood in the lumen that most likely to arise from distal jejunal or ileum. So the decision was conservative management that ended catastrophically by middle-aged male intubated, ventilated in the ICU after only 4 days of his first attack. His hemoglobin was 3 grams. His lab confirmed the diagnosis of DIC. So they sought intervention radiology advice, and again we responded immediately. As we see here in the conventional angiography, the first picture we see a large tortuous artery arising from the jejunal anastomotic arcade of SMA. This is called dialophy lesions. Coiling was done as we see on the second picture, yet still there is a contrast filling, so another coil was applied. As we see in the third picture, with no more extravasation, as we see, hemostasis was reached. This is an online picture of the lesion in the ileal branches where the black arrows point, and this is a real colonoscopy appearance of the lesion. Post-embolization follow-up was impressive as the patient extubated, discharged from the ICU after 5 days with no more attacks of bleeding. Again, a life was saved. Learning points. GIT bleeding is one of the most common practice we face, as it could lead to heroic bleeding. The first line of management is endoscopy or colonoscopy. Both celiac and SMA should be catheterized. Persistent catheterization of all anticipated branches that could be source of bleeding is mandatory. Indications for intervention is failure for endoscopy, bad general condition of the patient not fit for anesthesia, vascular malformation. Dialophy lesion is a medical condition characterized by a large tortuous arteriole in the submucosa that could lead to heroic bleeding if eroded. This is the end of my 2 cases. Dr. Abdelrahman will continue after me.
Good afternoon, everyone. Good afternoon, dear doctors. I'm Abdelrahman Mohee, radiology resident. I'm going to continue after my colleague, Dr. Maha. The first case is about emergency pulmonology embolization. This is an adult male known case of bronchiectasis with multiple recurrent attacks of hemoptysis. The current attack required hospital admission and blood transfusion. The pulmonologist sought our IR consultation to save the patient's life, as this attack led to significant hemoglobin drop, 7 grams, and the patient condition deteriorated. On reviewing the patient's CT, it showed multiple bronchiectatic cavities, as we see mainly on affecting the right lung, as well as multiple mediastinal and periaortic hypertrophied bronchial arteries with no evidence of ectopic ones. So our team's decision was to intervene, as the patient wouldn't survive another attack of hemoptysis. Coming to conventional angiography. On selective catheterization of right-sided diseased bronchial arteries, abnormal blush was noted, and followed by embolization using 300 to 500 microparticles. However, this was not the only one as expected. This is the control after the embolization. This is another artery. Another embolization. So this is the third bronchial artery that was catheterized with another bleeder as well. And this is the embolization. The patient condition post-embolization, the patient dramatically improved the stabilized medical course afterwards, and the hemoglobin rise after several packs of blood transfusion. So we have another life saved. So the learning points: persistent catheterization of all anticipated branches could be source of bleeding is mandatory. There is always not a single feeder to the bronchial artery bleeding. There are 4 variants of bronchial artery origin, so proper knowledge of the anatomy is mandatory. The DSA should always selectively catheterize bronchial, intercostal, subclavian, internal mammary, and inferior phrenic arteries to search for accessory bronchial arteries. Indications of bronchial artery embolization include massive hemoptysis in various cases, such as cavitary lung lesions, for example, TB or bronchiectasis, as in our case, aneurysm, malignancy. Used embolic agents ranged from large particulate agents, spheres, and microvascular plugs, as in cases of AVMs. Less commonly used are the gel foam and glue. My second case is about a lady that was in the CCU for coronary angio and pacemaker placement with difficult right puncture, so the diagnostic angiography was done through a left femoral approach and pacemaker was placed. However, after 24 hours in the CCU, the patient condition became critical. She was shocked. The hemoglobin dropped significantly. So an urgent CT with contrast was ordered, revealing a large retroperitoneal and pelvic hematoma with active contrast leak. 3D reconstruction revealed leaking pseudoaneurysm into the hematoma. Patient condition was not fit for general surgery, so intervention radiology was the last and the only resort for the patient. Left femoral puncture and right external iliac catheterization was done, and DSA images, as you can see, shows side branch leaking pseudoaneurysm to the peritoneal cavity and the pelvic hematoma, as marked by the arrows. A microcath was navigated to the site of bleeding, followed by embolization using MBCA lipidol mixture. Control angiography revealed total occlusion of the traumatic pseudoaneurysm with no contrast leak. The follow-up, the patient clinical condition markedly improved. She was vitally stable, discharged from the CCU after 48 hours, discharged from the hospital 24 hours after. The patient hemoglobin rised from 6 to 10 after 2 packs of blood, with no more hemoglobin drop noticed for the next 72 hours until her discharge. So we have another life saved as well. So basically, our take-home message for today: embolotherapy is becoming a cornerstone in the management of critical hemorrhage, either spontaneous, iatrogenic, or even traumatic. The aim is to occlude or decrease blood flow until reaching homeostasis. Emergency intervention radiology have to be included in the multidisciplinary team of ER as minimally invasive lifesaver. The last patient had no option except for IR. CT angiography provides crucial information about the bleeder, decreasing the procedure time and decreasing unnecessary radiation exposure. In some cases, bleeding could not be visualized, and we need provocation tests to reveal the bleeder. Wide variety of embolic agents are available, so familiarity of all agents should be essential, and there is not a suitable agent indicated for all indications. Post-operative follow-up by vital data and the clinical symptoms is a mandatory, as rebleeding is not rare. Thank you, everyone.
شكرا للشباب عين شمس، وبرضه